Today, we're going to talk about upper urinary tract anomalies. The importance of this subject is the high incidence it has. We can see it in 1 of every 100, 500 newborns. Are the most frequent nephrological anomalies diagnosed in utero, 3 of every 4, and are more prevalent in males than in women in a proportion of 5 to 1. Are usually associated to structural anomalies in 10%, which often are other genitourinary malformations of congenital heart defects and chromosomal anomalies in 2 to 5%. And it's important as well to acknowledge that 40% of them disappear. Regarding the pelvic dilation, we have to know it can be a transient anomaly, and between 66 to 92% of cases have an spontaneous resolution pre- or postnatally. It's the most frequent anomaly diagnosed prenatally. It's seen between 1 to 5% of the fetuses, and it's a chromosomopathy marker. If we see it, we have to perform a detailed anatomical study and look for other markers. But if it is isolated, we will not variate the risk of Down syndrome because its likelihood ratio is 1.08. The other possibilities can be seen in this slide. It can be an anomaly at the ureteropelvic junction, known as the ureteropelvic junction syndrome, or can be an anomaly at the uretrovesical junction, in which the ureter and pelvis will be found dilated. At this level, the most frequent are pieleureteral duplication, megureter, or vesicoureteral reflux. There is other possibility, which is at a lower level, at the urethra, in which case we will see a vesical dilation, with dilation of both ureters and even pelvic dilation. In this case, the two pathologies are the posterior ureteral valves or the urethral atresia. Frequently, what we see and describe prenatally is not the same of what the pediatric urologists see in the newborn. Although it is a very frequent pathology, we haven't come to an agreement in terms of measurements and criteria. This had made that different societies and different groups, as the American College of Radiology, Journal Fetal Urology, and Pediatric Urology, have published different papers in which there are consensus regarding terminology, cutoff, screening, and classifications. And in that way, we have different terms as dilation, which should be used always, and avoid using the term ectasia or hydronephrosis, which could lead to think of severity. We should also talk about urinary flow impairment and avoid the term obstruction, which is a postnatal terminology. The challenge is to select those fetuses that will benefit from a close monitoring and those who should be candidates for prenatal treatment. The problem is that this is a frequent pathology and the goal will be not to create unnecessary anguish and follow-up. For this, regarding the cutoff, more than 4 mm is in less than 33 weeks and more than 7 mm in more than 33 weeks have been considered. Good predictor of urinary flow impairment, always measuring the pelvis in an anterior to posterior diameter in an actual section of the abdomen. The multidisciplinary consensus introduced a new cutoff, which is from 28 weeks, 7 mm, and from 16 to 25 weeks, a pelvis of more than 4 mm will be pathological, and from 28 weeks, more than 7 mm, and in the postnatal stage, more than 10 mm at 48 hours after birth. Much of you may know this classification of the Society for Fetal Urology that takes into account the pelvic dilation, the calyceal dilation, and aspects of the parenchyma, but this classification has poor inter-observer reproducibility. So, the multidisciplinary consensus established this classification to differentiate those fetuses with high risk and those of low risk. If we had a fetus with less than 27 weeks and a dilation between 4 and 7 mm, or a fetus of more than 27 weeks with a dilation between 7 and 10 mm, with central distribution, which doesn't affect the calyces, will be considered as a risk of 1. But if from 16 to 27 weeks has more than 7 mm of diameter, or from 27 weeks has more than 10 mm of diameter, or has any of these criteria, as a calyceal dilation, a thickened parenchyma, abnormal ureters, abnormal bladder, or unexplained oligohydramnios will be considered a high risk, which will be classified as 2 to 3 risk. The dilation have been classified as well in mild, moderate, or severe, as you can see in this chart, in second and third trimester. So, if we see a dilation, we have to perform an exhaustive evaluation of the nephrourinary system. We should assess if it is uni or bilateral, the parenchyma, calyces, the ureters, bladder, and volume of amniotic fluid, which is an indicator of renal function. We shall try to locate the level of the anomaly, but it is usually difficult prenatally. Regarding the management, it is important to assess if it is uni or bilateral. It is also important to know if there is dilation of the peripheral calyces apart from the central ones, or if there is only dilation of the central calyces. Other important aspect is the corticomedullary differentiation, if it is correct with the Malpighian pyramids, or if it has an increased echogenicity. The parenchyma thickness, or if we see cortical cyst, or increased echogenicity of the edge. The cortical thinning is a subjective appreciation, but generally parenchymas of less than 3 mm are considered pathological. In a normal ultrasound, we should not see the ureters, because in normal conditions they measure 1 to 2 mm. Here we can see an elongated image, and in this case we can see a dilated ureter. And these are other images, which sometimes can be confused with the intestinal dilation. The bladder should be assessed as well. In this case, we can see a vesicle dilation with a keyhole sign. In a case of posterior urethral valves, with retrograde repercussion, we should also assess if the bladder walls are thick, or if we see an intravesical ureterocele. The amniotic fluid volume should always be assessed, especially if we are evaluating the renal function. We know that in pregnancies of more than 16 weeks is the reflex of the renal function. Therefore, oligohydramnios without any other cause should imply a renal failure. When we see a dilation, we have to make the differential diagnosis with the multicystic renal dysplasia, in which we see a kidney with cyst in different sizes, non-communicated, with an abnormal parenchyma. And in the dilation of the urinary tract, we will see cyst images which are communicated. The parenchyma is generally normal, unless there is an early obstruction, but sometimes it is difficult to make the differential diagnosis in prenatal life. We should also make the differential diagnosis with the abdominal or renal cyst, and with the suprarenal hemorrhage, that gives an image in the superior pole of the kidney. The ureteropelvic junction obstruction is the most frequent cause of hydronephrosis. Most of cases is unilateral, and in 25% of cases is associated to other anomalies, as the multicystic renal dysplasia, the posterior urethral valves, or the double system, or a horseshoe kidney. 12% of these anomalies are extrarenal, especially congenital heart diseases, and we know that in 5% of cases we can have a chromosomal anomaly, so we should offer an invasive test. What we will see in the pieloureteral junction syndrome is a pielic or pielocalyceal dilation, non-dilated ureter, although the most proximal portion sometimes is dilated. Frequently, normal parenchyma and a normal appearance bladder. When we see an uretrovesical anomaly, we will see retrogradely an ureter dilation. This condition can be found in the megureter, vesicureteral reflux, double system, and ureterocele. As we mentioned before, we see a dilated ureter that sometimes is difficult to differentiate from the intestinal dilation. What can help us is the peristalsis and the continuity to the bladder. We should make an exhaustive assessment of this, the variable dilation of the pielic, pielocalyceal dilation, normal parenchyma, and a normal bladder. The vesicureteral reflux is a retrograde permanent or intermittent flow from the bladder towards the ureter due to anatomical uretrovesical junction defect, which can be primary or functional. It is important in the infant population. It has a prevalence between 1 to 2% and constitutes between 10 and 30% of upper tract dilation. It is associated to double system, multicystic renal dysplasia, or unilateral renal agenesis. Here we can see a dilated ureter. It is important to acknowledge that the diagnosis is always made in postnatal period and will be made through a retrograde cysturethrography. The megarether is less frequent. It's a distal urethral narrowing with dysfunction or located dysfunction. Constitutes 10% of upper dilated pathology. The reflux is unlikely, and the incidence is 1 in 6,500 newborns. The ureter is visible, tortuous, and by definition are ureters of more than 10 mm of transverse diameter. The differential diagnosis with the vesicoureteral reflux cannot be made in prenatal life. Here we can see an ureter that is inserted pathologically inside the bladder. The ureterocele is a cystic dilation of the distal ureter, which is seen inside the bladder. In 80 to 88% of cases, it is associated to double system, and always a ureterocele is diagnosed, we have to look for a double system and vice versa. The ureterocele can be primary as well, unless it's infrequent. A simple one when it's inserted in the trigone, and ectopic outside the trigone. We will see it as an intravesical cyst. Here with color Doppler we can see the image. Color Doppler helps us identify the bladder. The double system is a highly frequent anomaly, 1 in 125 newborns. There are published series of 1 in 25 in post-mortem studies due to other reasons in people with advanced age. A dominant heritage has been proposed, and is one of the few anomalies in the urologic system that is more frequent in female. As the name implies, are two pielocalicial systems separated by normal parenchyma, with partial or completely duplicated ureters. This will be a total double system, and this will be a partial double system, because the ureters are joined and end in a single ureter in the bladder. The double system can be non-dilated. Here we can see a kidney that is a little increase in size with two renal pelvis, and the dilated, which is more easy to diagnose because claims our attention. In the double system, we will usually see a dilation in the superior part of the system that is usually a cyst, a renal cyst. But it can also be as a dilation of the inferior part of the pelvis, and that are separated by normal parenchyma. And always remember to look in the bladder for the presence of ureterocele. Now, I'm going to show you some videos of double systems. Here we can see the dilated ureters, the peristalsis, as we mentioned before. Here we can see another image of double system, and the image of both ureters reaching the bladder. Here other case of a double system. This is the superior pole, which is more dilated than the inferior pole. Then, we look for the ureter, and this image in the bladder, the ureterocele. Here we can see another case of ureterocele, in which we can see how it is emptying. Sometimes we cannot see the ureterocele because it has to be full to see it. And why does this happen? Because in the superior pelvis, that is usually the ectopic one, with a cystic appearance, has a ureter that reaches the bladder, and produces pressure to the other ureter, which then generates a vesicoureteral reflux, and the inferior pelvis is usually dilated. The non-dilated double system is very frequent. We always have to ask for the familial history, which most of the times is unknown, because if there are non-dilated having produced problems, and we should inform that they are a variant of normality. Which are the poor prognosis ultrasound images? First, the changes in the echogenicity or parenchyma thinning. In this case, the echogenic kidney or pelvic and calyceal dilation with normal parenchyma thinning with hypoplastic kidneys. Second, cortical cyst, as you can see here, or the appearance of urinomas or great dilations that regarding the renal function have poor prognosis. The decreased amniotic fluid, which is not explained by other case. And the last, the persistently dilated bladder. Now let's talk briefly about the obstructive renal dysplasia. Although, in these cases, the parenchyma and cortical development is correct, from the moment of an insult, the development will be conditioned to it. There can be a failure in the development, so in the moment of an insult, the kidney can react differently with the appearance of cortical cyst, increased endogenicity, abnormal parenchyma, or an urothelium damage. The earlier the obstruction is, can be of a similar appearance as the multicystic renal dysplasia. Here we can see the appearance of cortical cyst in a dysplasic kidney. Which is the management? Investigate the familiar history, because sometimes we can find someone in the family that had a renal problem, as unilateral renal agenesis or renal failure in the adult life. As we said before, we must rule out the presence of nephrological associated anomalies. Try to identify the level, which is difficult, but it will give us the tools to address the prognosis of this problem properly. Sometimes, the MRI can help us in complicated cases, although it's not in the guidelines. We must rule out the extra nephrologic complications. Always ask for an echocardiography and always offer an invasive procedure with array, because every time there are more and more publications in which there are chromosomal anomalies associated to renal anomalies. This is another published article in which some undetermined alterations of a rate have been associated to renal anomalies. Regarding the follow-up, we know that there is a consensus to classify the fetuses as high or low risk. This follow-up will be in low-risk fetuses. Just with a third trimester ultrasound will be sufficient. But those of high risk should have a follow-up of every 4 to 6 weeks, and after birth. Both should have a kidney ultrasound performed after 48 hours of life, because that there is a physiological dehydration and we could have a lot of false negatives. In low-risk fetuses, an ultrasound at the first month and then at 6 months should be performed, and those of high risk, after 48 hours of birth, and a specialist should have seen them to establish the treatment and follow-up depending on the severity. There are some situations, as the posterior urethral valves, that will need an immediate treatment after birth. Generally, in our population, the mild dilations are monitored at 28 and 33 weeks, and the moderate to severe dilations have a follow-up every 2 to 4 weeks, depending if they are bilateral or unilateral. We always perform another ultrasound at 37-38 weeks to evaluate the pelvic dilation. And if it is more than 10 millimeters, we should administrate postnatal antibiotics to reduce the risk of infections. Regarding the delivery, it should always be at term and vaginal. We should never variate the obstetrical management. Exceptionally, we can make a multidisciplinary consensus and end the pregnancy earlier, but through the years, we have thought of ending the pregnancy earlier, even premature, but with time we have evidence that this pathology needs time, except with the posterior urethral valves. So there was no indication to end the pregnancy earlier. And the question is there any indication of intrauterine therapy? In some cases, yes. And in which pathologies is indicated? In urinum or compressive cysts, which are compressing the parenchyma, and also in the urethral cell, which can invade the urethra and provoke an obstruction, with impossibility of urine outflow. In these cases, a decompressing puncture will be indicated. Which is the prognosis of upper urinary tract dilations? These are the typical questions of the parents. If the kidney will function properly and if their baby will need surgery. Generally, have good prognosis. Between 30 to 40% of cases have an spontaneous resolution the first years of life, and less than 20% of cases will require surgery. The prognosis will depend in the laterally and severity. The measurement in the prenatal life usually does not correspond to the postnatal measurement, and never is related to the prognosis regarding the renal function. But the measurement can be an indicator of necessity of surgery, and so, the renal pelvis of more than 15 millimeters in more than 33 weeks, or, as has been stated in recent publication, the renal pelvis and the parenchyma thickness ratio with a sensibility of 83 to 87% and a high specificity as well, can predict the necessity of surgery. The prognosis regarding renal function can be assessed by the ultrasound parameters, especially the decreased amniotic fluid, and with biochemical parameters. The urine electrolytes have been well studied through a vesicocentesis and in blood through cortosynthesis. B2 microglobulin is a protein that a glomerular lever has a similar function to the creatinine and will mark the glomerular function when analyzed in blood. In urine is a parameter of tubular function. Therefore, B2 microglobulin should be reduced in blood if there is a correct filtration process and in urine if there is a correct tubular reabsorption function, also calcium and sodium. To obtain a correct sample of urine, several vesicocenteses should be made, and this logically has risk of bladder wall damage and discomfort in the patient. This will be indicated exclusively to evaluate the renal function prior to intrauterine surgery. The postnatal management in our center is antibiotic prophylaxis if the pelvis is of more than 10 mm in the antenatal ultrasound. Perform an ultrasound in 7 to 10 days to avoid the physiological dehydration. Perform a retrograde cysturetrography to prove if there is a reflux or not. An isotopic renogram, which will indicate if there is a partial or complete obstructive pattern. And finally, the gammography to assess the renal function. To end, the conclusions are: upper urinary tract dilations have high incidence and are prenatally detectable anomalies. 40% of them disappear. They generally have a good prognosis. The prenatal dilation does not correspond to postnatal dilation and does not have prognosis value regarding the renal function. Exceptionally, the obstetrical management will be modified. Pelvic dilation is a predictor of possible obstructive pathology, and dilations of more than 7 mm in more than 28 weeks are suitable for postnatal follow-up. Prophylactic conservative management with antibiotics is still indicated in the majority of children. The ultrasound follow-up with isotopic studies should be done until 2 years old. Less than 20% of children with upper urinary tract dilation require surgery. And thank you very much.